and welcome to this session of poster podium presentation in Neuro Ophthalmology. We will start with non-competitive talks, and first talk is by Dr. Karthik Kumar Mani, and he'll be talking. Is he there, Dr. Karthik? No, sir. He's not here. And Dr. Roshni Chokliwala, she is there. So, Dr. Roshni, you please come and present your talk. You are not a ratified member? Please. Most welcome, and you will be talking about yeah. You're talking something interesting about Wallenberg syndrome. That's very good, Dr. Roshni.
Should I begin?
Please do. Go ahead.
A very good morning to one and all. Today I will be presenting a case of MTHFR mutation in a young male presenting with Wallenberg syndrome. So to begin with, Wallenberg syndrome is a neurological disorder that occurs as a result of damage to the lateral segment of the medulla posterior to the inferior olivary nucleus. Most common causes are stroke involving the vertebral artery or the posterior inferior cerebellar artery. Now, the classical risk factors of cerebrovascular accidents like hypertension, diabetes, and cardiovascular disease are not always applicable to young patients who experience a stroke. So, extensive research has shown that hyperhomocystinemia is one significant and possibly modifiable risk factor. Homocysteine is a metabolic product of methionine breakdown. Its further metabolism requires vitamin B12, B6, and folic acid, as well as the optimal functioning of the enzyme methylene tetrahydrofolate reductase. So, elevated homocysteine levels can be either due to deficiency of vitamins B12, 6, and 9, or because of an MTHFR gene mutation, and sometimes both. Coming to the case report, a 47-year-old male presented to us with sudden onset swaying to the right and numbness of the right side of his face since 2 days. He subsequently developed binocular diplopia with vertical separation of images. He was a hands chewer and had no other known comorbidities. On examination, he had diminished sensations over the right side of his face and left side of his body, gait ataxia, left hypertropia with skew deviation, and horizontal gaze evoked nystagmus. His CT angiogram of the brain showed a right lateral medullary infarct. Blood reports revealed hyperhomocystinemia and vitamin B12 levels at the lower limit of normal. MTHFR mutation was found to be positive in this patient. So, Wallenberg syndrome typically affects older individuals with known vascular risk factors like hypertension most commonly, followed by smoking and diabetes, which causes an atherothrombotic occlusion. The most important cause to rule out in younger patients with Wallenberg syndrome is a vertebral artery dissection and hyperhomocystinemia. Hyperhomocystinemia creates a prothrombotic state which leads to a stroke, and an important factor in regulation of this homocysteine is MTHFR gene. The MTHFR gene codes for the enzyme methylene tetrahydrofolate reductase. So, 5,10 methylene tetrahydrofolate is the primary form of folate in circulation, which in the presence of the MTHFR gene is converted to 5-methylene tetrahydrofolate. This 5-methylene tetrahydrofolate with vitamin B12 will convert the homocysteine back to methionine, and then it is either excreted in the urine or finds its way back in the cycle. So, defect in the MTHFR enzyme will lead to hyperhomocystinemia, creating a hypercoagulable state. Wallenberg syndrome is seen more commonly with atherothrombotic conditions, and it is rare for a prothrombotic state to lead to Wallenberg syndrome. To the best of our knowledge, there is only one case series comprising of 2 cases of hyperhomocystinemia leading to Wallenberg syndrome in published literature. In patients belonging to younger age group, it is essential to rule out hyperhomocystinemia due to genetic as well as other causes, especially when there is no known underlying comorbidity. Our patient was found to have MTHFR gene mutation and his B12 levels were at the lower limit of normal. So, vitamin B12 is a cofactor in the conversion of homocysteine to methionine as well, and lowered vitamin B12 paired with the MTHFR mutation was the cause of hyperhomocystinemia in our patient. In conclusion, it is essential to investigate the cause of hyperhomocystinemia in young patients who present with a stroke, as identification of genetic predisposition improves the understanding as well as of the etiology, as well as prevents recurrence in the future.
Thank you. It's a very interesting presentation. In fact, this Wallenberg syndrome is known as lateral medullary syndrome, and this is due to infarction in the posterior inferior cerebellar artery.
Yes,
And they have a very wide presentation because a lot of structures are passing down,
Yes.
and one of them is skew deviation, which you pointed out, because the autolytic pathways are also passing, ascending up in that area. So that can add to a vertical deviation and can have a very interesting presentation. They sort of push to one side, that is lateral
Yes, sir.
pulsion, to the opposite side, I think, if
Yes,
I
sir.
remember rightly.
Yes, sir.
So a very interesting, neurologically very interesting syndrome. And thank you for a very nice presentation. Unfortunately, you are not a ratified member, so we'll not be able to include you in the assessment.
Okay.
Thank you so much,
Thank
and
you.
wish you all the best in future.
Thank you.
Now the next talk, we move on to the next talk, and that is Dr. Shamanya Mani. Is she there? Saranya Mani.
Saranya Mani is there?
Yes, series of fibro-osseous lesions of paranasal sinuses and their ocular manifestation. She's not there, I think. So shall we mark her absent then? I asked him, he said all are present,
Okay, they were there.
And this first non-competitive, has she come? Dr. Sharmila, you are there? Yes, sir. Please come and present your... You are also not ratified member? Yes, sir. You are not ratified? Yes, sir. All right. All the best for future. And you will be talking about sudden vision loss due to acquired bilateral lateral geniculate body necrosis. Isolated lateral geniculate body necrosis. That's another very interesting presentation, I would say. I wonder if, okay, you go ahead.
Good morning, Honorable. I will be presenting today sudden visual loss due to bilateral lateral geniculate body necrosis. Bilateral lateral geniculate body necrosis is a rare entity because of its high metabolic rate and dual blood supply. We collected all the data from electronic medical records of our hospital and discharge summary from the previous treatment center from the patient. 22 years old female who is obese postnatal presented to our OPD with history of fever, abdominal pain, vomiting, headache and loss of consciousness, followed by sudden loss of vision in both eyes after 1 week. Patient was also on paleo diet for weight loss. She was diagnosed as acute pancreatitis elsewhere and was treated as bilateral optic neuritis with injection methylprednisolone elsewhere according to ONTT trial. On ocular examination, both eye visual acuity was grossly reduced, right eye more than left eye. Pupillary reflex was sluggish in both eyes, which was 5 mm dilated. Anterior segment and post fundus examination were normal. Visually evoked potential was prolonged latency in both eyes. Visual fields could not be documented owing to low vision. So, we were in a surprise because this patient was diagnosed as bilateral optic neuritis. We again subjected the patient to MRI brain and orbit. So we were in a surprise since the MRI showed bilateral subacute hemorrhagic necrosis in the region of lateral geniculate body. So investigations at the time of acute pancreatitis showed elevated serum amylase and WBC count. Chest CT abdomen also confirmed acute pancreatitis. So we had a discussion with neurologists and radiologists. Then she was referred to the multi-specialty hospital where she was managed by a team of neurologists, hematologists and gastroenterologists. So this is the MRI picture of the patient showing red arrow shows the symmetrical changes within bilateral lateral geniculate body with foci of blooming on susceptibility weighted imaging concerning for hemorrhagic necrosis. This CT scan of abdomen showing pseudocyst within uncinate process and bulky pancreas in the right side. Finally, the patient was diagnosed to have bilateral LGB hemorrhagic infarct owing to acute pancreatitis due to thrombotic etiology. Follow-up MRI revealed resolution of flare hyperintensity in bilateral LGB with residual blooming suggestive of old hemorrhagic gliosis. Visual acuity slightly improved with a possible field effect which could not be documented owing to reduced vision. Both eye fundus discs showed temporal pallor. This is the follow-up MRI showing residual blooming on susceptibility weighted imaging with resolution of diffusion weighted imaging and T2 changes. Discussion, isolated lesion in bilateral lateral geniculate body is an uncommon cause. In fact, there have been only few cases of isolated bilateral lateral geniculate body reported in the literature. The anterior part of LGB is supplied by anterior choroidal artery and remaining by posterior choroidal artery. So the mechanism for isolated LGB lesions are vascular occlusion and osmotic demyelination. Till date, all reported and documented cases of isolated LGB lesions are females, as also in our case. The dilemma which is there is by chance or whether this is real association, it needs to be really evaluated. We conclude that all lesions of LGB or hemorrhagic infection and osmotic demyelination. In our case, we postulate vascular pathology, possibly hypoperfusion due to shock following acute pancreatitis. Hence, isolated lesions of lateral geniculate body should be also considered while evaluating for the causes of bilateral sudden loss of vision. These are my references. Thank you.
Thank you. Very interesting presentation. Only thing, pupils were also affected. Now, you think they were affected because of poor vision in both the eyes, or because the pupillary fibers were also involved before they could leave the AGN and take their course? That's one thing. Another thing, the lesion here, is it vertebrobasilar system or the carotid system? I think this is a gray area which could be, I think, mostly supplied by the vertebral system as it is going up. And these choroidal vessels, I don't remember exactly the anatomy. Did you look up at these anterior and posterior choroidal vessels which you were talking? Where from they are coming? They are from the carotid system or they are from vertebrobasilar system? I think that will be interesting. And maybe it was one perforating branch from the vertebral system as it is ascending, which has given rise to bilateral lesion. So because it is bilateral, so I think it has to be one vessel which has probably caused it. Thank you so much.
Thank
Very
you,
interesting presentation. Now, we move on to the first presentation. Dr. Srivastava will be talking about, what is your talk? Field changes in automated Humphrey analyzer in tuberculosis following ethambutol therapy. Yes. Dr. Purva Srivastava.
Good morning, respected dignitaries. I, Dr. Purva Srivastava from Bhopal, would be making this presentation. The title of my presentation is Field Changes on Automated Humphrey Field Analyzer in the Tuberculosis Patients Following Ethambutol Therapy. A little bit about the introduction. The study was conducted to evaluate the visual field changes in tubercular patients on ATD therapy and to assess the reversibility of these changes after the discontinuation of the therapy. The primary objective of the study was to analyze the visual field changes following initiation and to also assess the regression and also if there is an improvement in visual acuity after the stoppage of the ATT. This study was conducted as a prospective analytical study at tertiary care centers in central India on newly detected tuberculosis patients who presented to us. Ocular history, relevant history was recorded. Detailed ocular examination was done at the time of presentation, that is before the initiation of ATT. Then all the patients were followed up periodically till the cessation of treatment and 3 months thereafter. The total duration of my study was approximately 18 months. So we had a total of 40 cases of newly diagnosed tuberculosis who were registered with us. The mean age was around 38.4 years. We documented a significant deterioration in visual acuity after 3 months of the initiation of therapy. And once the ATT was stopped, the improvement in visual acuity was statistically significant. That is 3 months after the cessation. And the p-value was less than 0.05, so which proves that it's statistically significant. Color vision and visual field effects were observed in higher proportion of eyes following initiation of ATT therapy, ethambutol precisely we are focusing on. And this also improved significantly after 3 months of the cessation of the therapy, p-value being less than 0.05. So my conclusion is that ethambutol, even in recommended doses according to DOTS program, has been associated with ocular toxicity which manifests in the form of painless progressive loss of vision, color vision defects and visual field effects. Though these changes are usually reversible, but in few patients we do have irreversible damage as well. So the patients who are receiving these therapies and who come to us for evaluation, they have to be explained about these probable side effects, and they have to be warned about the periodic follow-ups. Follow-ups have to be mandatory. And these are tables that I made regarding the visual acuity and the field changes. So the major field change which I observed was central scotomas and centrocecal scotomas, followed by peripheral constrictions and defects and peripheral defects mainly after that. This is one of the Humphrey Field chart of one of the patients showing central centrocecal scotoma. Some of the references. Thank you.
So you have not done that your VEP and RNFL.
No, sir. In none of these patients.
Okay.
And your patients were all pulmonary cox, or there was some CNS tuberculosis also, like meningitis, because then presentation could be there because of those aspects also.
So majority of my patients were pulmonary TB patients. Very few out of 40, less than 5 were extra pulmonary.
No, if there was any CNS tuberculosis, then I think you should have taken them out with this kind of assessment, because
Yes.
then whatever you are
Other
describing
causes.
could also be there because of the tubercular meningitis or other factors which could give rise
have
to
been
neurological
contributed.
lesions. And you have had very high incidence, rather high incidence of toxicity. Any reasons you can think of why you had?
So most of the patients, they were coming to us in the government setup, and they were enrolled with the DDoTS center that we had, and compliance, and not just with us, I mean with the pulmonary specialist also was very poor. So that's why, I suppose.
So were they diabetic or any other systemic disease?
Yes, since the mean age that we had was 38 years and plus that, so yes, they had systemic complications. Some that were coming to us had diagnosed complications at DM and hypertension, and some they were not even aware of their status.
So they were not on dialysis or some kidney disease they were having, because
no,
in these
not-
patients you find
Yes.
more of ethambutol toxicity.
Because they add up to the clearing by the kidneys, you know. If the kidney
Yes.
functions are not good, then obviously the drugs are more in the circulation.
Yes.
Interesting study, and I think we need to analyze why you have had much higher
Much higher
incidence
incidence. Yes.
of toxicity. Thank you so much,
Thank you,
Dr.
sir.
Purva. And marks देंगे. Now the next presentation is Dr. Trishna Taye. She is there? Yeah, please come. And you are presenting spheroidal fungal sinusitis and vision loss, a case report. Please start.
Good morning, judges and all. I will be presenting my case report on sphenoidal fungal sinusitis and vision loss. Fungal infection of the paranasal sinus was first reported by Jarnico in the 18th centuries. Sphenoidal fungal sinusitis is rare in immunocompetent patients. Infections involving the sinus is associated with dangerous complications because of the location and nearby important structures. It is commonly seen in female elderly patients with diabetes, hematologic malignancies, prolonged use of steroids, etc. Here we report a 38-year male patient who presented to us on June 2020 with severe complaints of left-sided painful gradual loss of vision with chronic headache, not relieved by conventional analgesic since 1 month. There was a history of IV solumedrol which was given elsewhere 1 month back, following which patient became perception of light negative. There was no significant past and systemic illness. On examination, right eye best corrected visual acuity was 6, 6, and 6 with normal anterior and posterior segment findings, but in the left eye, perception of light was negative, RBD was positive, there was a limitation in the abduction movement, and on fundus examination, there was chronic disc edema. An urgent MRI brain was advised, which reveals ISO to high signal intensity in T1, W1, low signal intensity in T2-8 image in left sphenoid sinus with expansion and bony destruction of sinus walls encasing the apex of left orbit and compressing the left optic nerve, features suggestive of fungal sinusitis of sphenoid sinus with mucocele formation. Left-sided optic neuropathy due to fungal sinusitis of sphenoid sinus was diagnosed provisionally, and patient was referred immediately to ENT and neurosurgeon for needful. Patient was lost in follow-up for a few weeks. During this time period, he became COVID positive and he was admitted on a local hospital from 15/7/2020 to 29/7/2020. After discharging from COVID ward, he had undergone endoscopy skull-base surgery on 30 July 2020, followed by histopathological examination confirming aspergillus fungus, and he was given IV voriconazole 400 mg BD on day 1 and then 200 mg IV BD for next 10 days, and patient was advised to come after 10 days with the ENT surgeon. But patient came back to me with diminution of vision of the right eye after 5 months. Then he was again referred back to ENT and neurosurgeon as well as to higher center for needful. From this case report, what we can understand is that sphenoid fungal sinusitis are associated with dangerous complications like loss of vision, ophthalmoplegia, etc. And it manifests commonly with chronic headache and retroorbital pain. The frequency of visual disturbance is 24 to 50% of sphenoid fungal ball cases in previous studies. To conclude, early neuroimaging, early diagnosis, and timely surgical interventions is crucial for the improvement of vision and patient survival, because sphenoid sinusitis is an uncommon but it's a treatable cause of optic neuritis, and intracranial extension was the only statistically significant factor for poor survival. These are the references. Thank you.
Thank you, Dr. Iyer, for a very interesting presentation. Only thing I wanted to know, it was a sphenoidal sinusitis, fungal you are saying.
Yes, sir.
What fungi was isolated? Did she have any COVID background or immunocompromised? This was a lady.
No immunocompromised. He was COVID positive after the diagnosis of the sphenoid fungal sinusitis.
It's strange, very strange.
That's
I
what-
don't- yeah.
And other thing is, initially it presented on one side, and you were saying the
Yes,
sixth
yes.
nerve was also affected. Was it on the same side or the opposite side, the sixth nerve?
He was PL negative when patient came to me. Then he became right eye vision became counting finger 3 meter after 5 months of the endoscopic sinus surgery.
No, the sixth nerve which you were saying was affected on the same side of
Left side, yes sir, same side.
same side.
Same
So
side, yes.
how these two were related? What do you think was the relationship between sphenoid sinusitis and sixth nerve?
It was fungal sinusitis. It was compressing the optic nerve and the apex of the orbit.
And sixth nerve, how was it affecting the sixth nerve?
If it was affecting the apex of the orbit, then another nerve, cranial nerve should have been affected. No?
It was not only the abduction was only limited.
That is what you should have
Yes.
put your mind to that, because optic nerve is having a different anatomical location as compared to the sixth nerve. So probably the lesion was also extending to the cavernous sinus,
Sir.
and sixth nerve is supposed to be a free-floating nerve in the cavernous sinus as compared to the third and fourth, which were fixed to the lateral side of the cavernous sinus. So maybe it was an early affliction in the cavernous sinus lesion, and this was a fungal etiology. It did respond to treatment, is it? She got better ultimately? We don't know.
He did not come to me, sir.
So you don't know ultimately what happened.
I called up the patient, and then he is alive, but he's saying that left eye vision already gone. Right eye, some amount of vision is left.
Okay, thank you for a very interesting presentation, and thank you so much. And next talk is by Dr. Anisha
Sarkar, yeah.
Sarkar. Changing trends of etiology of papilledema before and after COVID pandemic.
Good morning, respected dignitaries. I will be talking on the changing trend of etiology of papilledema before and during the COVID-19 pandemic. So to begin with, papilledema is a passive hydrostatic swelling of the optic nerve, is secondary to raised ICT, and it has special clinical significance because even a slight increase in the CSF pressure surrounding the optic nerve due to raised ICT leads to development of papilledema, which can be a major indication regarding an underlying intracranial pathology. From our study, we have observed that during the COVID-19 pandemic, there is an increased incidence of papilledema due to CVT cases that can be attributed to the hypercoagulable and the pro-inflammatory state triggered by the COVID-19 infection. It was a retrospective study carried out on the patients presenting with papilledema in our Neuro Ophthalmology clinic. There were 243 patients were divided into two groups, the pre-COVID and the COVID group. Coming to the results from our study, the incidence of papilledema in the pre-COVID and the COVID group were almost similar. Also, 80% were females in both the groups, and the mean age of presentation was 33.5 years in both the groups. Coming to the most common presenting symptom, it was headache associated sometimes with vomiting in both the groups. Now, as far as the visual acuity is concerned, it was most of the patients presented with a visual acuity of 618 or better in both the groups. However, we have found that the number of patients presenting with a visual acuity of less than 618 was much more in the COVID group compared to the pre-COVID group, with a statistically significant p-value. As far as the neuroimaging is concerned, in both the groups, the most common etiology is IIHT. However, we have found that in the COVID group, there is a significantly increased number of papilledema cases due to CVT, which is 23% compared to the pre-COVID group, only 11%. Again, the p-value is statistically significant. Moving on to the discussion of my case, the optic nerve is formed by retinal ganglion cells which connects the retina to the brain. So the anatomy of the optic nerve makes it a very sensitive marker for the intracranial pathologies. From our study, we have found that there was no significant change in the incidence between the pre-COVID and the post-COVID groups. So also the presenting symptoms is a headache associated with vomiting in both the groups. However, in the visual acuity, we have found that the number of patients presenting with less than 618 visual acuity was much more, with a statistically significant p-value in the COVID era. As far as the etiology is concerned, IIHT was the commonest etiology in both the groups. However, number of patients with papilledema presenting with CVT was increased in the COVID era. A few words on COVID-19 associated coagulopathy. As many other viral infections, COVID-19 is also associated with coagulopathy, and the COVID-19 associated coagulopathy is a new term coined for this. There is dysregulation of natural anticoagulants. However, lack of thrombocytopenia, which distinguishes COVID-19 associated coagulopathy with DIC and microangiopathy. COVID virus has tropism for choroid plexus epithelium. This suggests a mechanism by which the viral infection may dysregulate CSF hemodynamics. Another striking observation from our study is that though IIHT is by far the most common etiology of papilledema, but among the males, only 17% were affected by IIHT, where 50% had CVT. From the neuroimaging, we have observed that superior sagittal sinus and transverse sinus were the most commonly associated sinus, and the type and the number of sinuses involved do not correlate with the ocular signs and symptoms, and both these findings were befitting with the results of our previously conducted studies. So to conclude, our study reveals an increased incidence of CVT in the COVID era compared to the pre-COVID era, but since we do not have any substantial evidence regarding the COVID-19 PCR status of all these patients presenting with CVT, we cannot conclusively say that the rise in incidence is a result of COVID-19 infection. Also, two other interesting findings from our study is that above 40 years age group, the percentage of intracranial tumors rises to 24%, and so we should be very careful while treating patients above 40 years of age group presenting with papilledema. The second thing is that among the males, the incidence of papilledema due to CVT is 50%, so that should again raise an alarm while treating male patients with papilledema. Thank you.
So they were presenting after how many days after having COVID to your department with vision loss or with papilledema or the transient visual obscuration? After how many days?
Sir, actually it was conducted in the first wave of COVID, and we went for few patients we did we had the RT-PCR status of the patients, but for we did the patients were studied in the first wave of COVID, and it was not fixed how many days they came after the COVID PCR status. Also, we do not have the COVID PCR status of all the patients presented, but since we have an increased incidence of CVT, we assume that might be attributed to the COVID-19 infection.
Because there are two things. One, if the patients are having high this FDP or D dimer level, that means they were severely affected with COVID, first thing. And the second thing, if they were having CVT or CVST, so they were having some neurological symptom or not?
Yes, sir.
Because if they are having neurological symptoms, then
Most of the
definitely they would
patients
not
are-
be coming to your OPD first. They would be going to the neurologist or the neuro ICU first.
So they presented to us with papilledema and we referred the patient to the neurologist.
What he's slightly saying, is it isolated papilledema or
Isolated papilledema, sir.
Palsy, papilledema quite often also has, for example, sixth palsy, which is a false localizing sign. So another thing, probably had you taken only CVT patients which were presenting with papilledema and shown their MRI, and so that would have been probably more.
Yeah.
Than taking the entire population of papilledema, and females were 80% of your patients were females,
Yes, sir.
and you were probably attributing it to IIH, to my mind.
Yes, sir,
With,
but
of course, females are affected more, but such a skewed presentation, I think, is a bit more. But I think better thing would have been to study CVT in these, whatever CVT you had, and findings in those with papilledema. I think that would have been, and every CVT may not present with papilledema also, I think, so depends upon what stage it is, and which sinuses are involved. And most important, other findings which were associated with papilledema will be very important to localize which sinus is primarily affected. So good study, but could have been done in a better way. Thank you so much.
thank you, sir.
Now the next talk is by Dr. Anzi Nagpal. She's there? Anita Nagpal. Aniza Nagpal, yeah. And she will be talking of rare case report of chronic myeloid leukemia presenting as unilateral optic neuropathy. Sorry, Aniza, for wrong pronunciation.
No, all right, sir. You on it? Good morning, everyone. I am Dr. Aniza Nagpal from AIIMS Bhopal. I am presenting a rare case report of a chronic myeloid leukemia presenting as unilateral optic neuropathy. A 55-year-old patient came with a chief complaint of diminution of vision for 3 days, which was sudden, painless and progressive. It was not associated with any other symptoms. Patient was non-diabetic and hypertensive for 5 years. And on ocular examination, the right eye had the vision of 624 with dyschromatopsia, and on swinging flashlight test, there was an RAPD of grade 2 in the right eye, while the left eye was within normal limit, and rest of the anterior segment findings were normal. On the fundus examination, there was marked disc edema, and the disc margins were blurred with disc elevation. There was also venous tortuosity and peripapillary hemorrhages seen along the inferior temporal and inferior nasal arcades in the right eye, while the left eye was within normal limit, and left eye fundus was normal. This is the OCT RNFL thickness was 245 in the right eye, in contrast to 97 micrometer in the left eye. This is the 3D evaluation, which is showing marked disc elevation. And then on blood investigation, a provisional diagnosis of non-arthritic anterior ischemic optic neuropathy was made based on his systemic risk factors as diabetes and hypertension as well. And the CBC was with ESR and CRP were advised to rule out arthritic AION. ESR and CRP came out to be normal, but the CBC was highly raised with blast cells 6%, myelocytes 16%, and metamyelocytes 11%, suggestive of myeloproliferative disorder. Therefore, BCL ABR rearrangement PCR test was done, which came out to be highly positive, and the bone marrow biopsy was done, which confirmed the diagnosis of chronic myeloid leukemia. So therefore, the treatment with tyrosine kinase inhibitor was started along with supportive treatment, and the MRI and with brain and orbit was done to rule out the CNS involvement. And then the MRI, axial section of T2 weighted MRI with fat suppression of the orbit showed a normal MRI with no CNS involvement, and the lumbar puncture revealed clear CSF fluid with normal constitution, and no atypical or blast cells were found. On follow-up visits, after 2 weeks of initiation of chemotherapy, there was reduction in disc edema, decrease in the RNFL thickness, and improvement in visual acuity to 612. But the patient stopped imatinib, was stopped due to thrombocytopenia, and which led to the development of edema in the opposite eye as well after 1 week of cessation of chemotherapy. The lumbar puncture was done to rule out raised ICT. The lumbar puncture with CNSS manometry revealed CSF opening pressure of 150 mm of water with clear CSF and not atypical or blast cells. This is the fundus picture where there is a presence of disc edema and peripapillary hemorrhages in the right eye, where with initiation of edema in the left eye as well. Then on consultation with the oncologist, the imatinib was restarted. After another 2 weeks, the patient had significant reduction in TLC and resolution of the optic nerve had edema in both eyes. On follow-up visit at 6 weeks, the BCVA in the right eye improved to 6.9 and 6.6 in the left eye. The color vision came back to normal and the fundus disc margin became clear with generalized disc pallor in the right eye and superior disc pallor in the left eye. And OCT RNFL also showed decreased RNFL thickness in both eyes. These are the visual field testings, which is showing the patient's visual field was affected with visual field loss. And discussion, optic nerve involvement is commonly seen in patients with leukemias. However, it is rare to see an isolated optic nerve involvement as a presenting feature. Our case reports one such rare scenario where the blood investigations done after the patient presented with the unilateral optic disc edema paved the way towards the timely diagnosis of CML in its chronic phase itself. Therefore, it is important and it is also important to distinguish the different etiologies of optic nerve involvement for the cause specific management. Then optic nerve, conclusion, CBC is an important diagnostic consideration in patients who present with optic disc edema, which might pave way towards its systemic association. And patients with ophthalmic manifestation have reported to have lower 5-year survival rates. Therefore, patients with leukemia must be screened for ophthalmic manifestations as it changes the prognosis and requires prompt management. Timely management directed towards the cause can help us improve the disease outcome. Thank you.
You did not show any MRI showing the infiltration of the optic nerve or anything. What do you think was causing that optic nerve involvement?
Sir, in CNS, there is, just a second. Sir, actually the optic neuropathy in CML can be due to inflammatory regions, can be due to infiltration, can be due to ischemia, or can be due to the side effects of tyrosine kinase.
So what happened in your case?
Yeah.
Sir, I most likely suspect to be an ischemic cause because due to the, when we did the CBC, the CBC were highly raised and due to hyperviscosity syndrome, the paraoptic branches must have been led to the ischemia of the optic nerve head.
Can you show the fundus picture again?
You did not show. She didn't show the presentation. You did not show us.
Yeah, that fundus picture I did not have.
Yes, you should have.
Yeah, definitely.
That was the most important aspect, and you diagnosed the non-arteritic optic neuritis.
Yes.
That was also important to see. Look at that picture.
Yes, sir.
Because the picture quite often is quite characteristic and will give it away. So
we thought it is a case of anemia, so we did not.
Because the treatment would have had changed. If it would have been a optic nerve infiltration, then the intrathecal chemotherapy has to be started.
Yes, sir. There was no signs of infiltration. Therefore, we went to also the visual field effects also are showing that the visual field loss is more pronounced in the inferior half, and ischemia of paraoptic branches, like due to hyperviscosity and anemia, like could be the cause of segmental involvement of the inferior optic nerve, and to further progress to involve the superior field as well. Therefore, most likely.
But you have not been able to produce any evidence. Your evidence is indirect. It is more of sort of.
Yes,
speculation.
it is retrospective.
It is more of speculative.
Yes,
that is my difficulty in this kind of situation.
Yeah.
You have been able to produce.
Sir, but there were no signs of infiltration, and also there was no CNS involvement, both on MRI and lumbar puncture.
Yeah, lumbar puncture. You said CSF. They were not showing any cells and
yes.
infiltration.
So there is twice MRI was done, LP was done. Never a sign of a CNS involvement was seen. So it is unlikely due to.
Usually, it is not infiltrated. In AML cases, it is infiltrated. We have seen unilateral. Yeah.
Those are other reasons are more speculative and actually because we need some evidence.
Yes, sir.
Anyway, it is very interesting presentation. Thank you so much.
Yes.
And you did not do any protein angiography to show any disc vessels and you did not.
Disc staining was seen on apophysis. Also because.
Okay.
It could have been done.
That would have probably given you
because
some
of the
input.
paucity of only 12 slides were allowed, so I did not include it.
No, but you should include slides which are more important. That is what is to be learned. Thank you.
Yes.
Very good presentation.
Dr. Chaitra Dambala Arur is there.
आगे पहुंच गए कहाँ पे हो?
Sir, यहाँ पे आ गए.
Last में.
हाँ, last one.
She was Anisa. You will be talking about
CNS
Lord of the Rings.
Yes. Good morning, everyone. The title for my presentation is Lord of the Rings. In due course of time, you'll know why. So here we've included 10 patients retrospectively evaluated, a series of patients presenting with ocular symptoms but a relatively normal ocular evaluation, diagnosed with psychosomatic illnesses. So the clinical presentation, 80% of our patients presented with chronic headache, 90% of them with progressive blurring of vision. Fundus evaluation was normal in 40%, disc edema in 30%, and pallor in the rest of the patients. All our patients presented with color vision deficiencies. RAPD was noted in 60% of our cases, and severe field loss was seen in 70%. So I'll be presenting one of the cases from the series to represent this study better. This is a 40-year-old lady who comes to us with headache since 2 months, blurring of vision since 20 days. She had a history of abscess in the neck 2 months back and history of generalized convulsions in 6 years. She consulted a local ophthalmologist who attributed her symptoms to amblyopia in the left eye because most probably there were not too many signs at that time, and she was advised a psychiatric consult, and then she was put on antidepressants, and she also had suicidal tendencies afterwards. Then she was referred to us with the and on evaluation of vision of 6/9 and N8 in the right eye, 6/18 and N18 in the left eye. Her color vision was defective in the left eye, and on pupil evaluation, when you shine this light torch from one eye to the other, you can see that there is RAPD in the left eye. Fundus evaluation was relatively normal except for the presence of chorioretinal atrophic patch of 1 disc diameter in the right eye superior to the disc. A visual field analysis revealed grossly depressed fields in both the eyes. So we went ahead with neuroimaging. As you can see here, there is a cluster of well circumscribed hyperdense confluent ring enhancing lesions near the chiasma, which you can clearly see over here, which is suggestive of CNS tuberculoma along with opticochiasmal arachnoiditis. So in short, I come back to the title of my topic, Lord of the Rings. As you can see here, the rings are lording over the opticochiasmal area, compressing the optic nerves, leading to the blurring of vision. So she was advised a neurology and a physician consult, and she was started on AKT4, and along with this AKT cover, she was started on IVMP as well. At 1 year follow-up, her vision and field started improving, but by then the disc pallor had set in. These are the profiles of the rest of our patients. So to conclude, tuberculosis of the CNS is a most severe and life-threatening form of the disease. A good clinical history and a thorough ophthalmic evaluation is simple and possible even in the most basic clinical setting. A good understanding of pupillary examination and the need for color vision assessment is an invaluable resource in guiding the clinician in the right direction, be it to tailor the investigations or intervene in case of life-saving emergencies. Thank you.
These are only chiasmitis, no other tubercular involvement in the CNS. That is, and you had one case or
10 cases.
10 cases and all showing only chiasmal involvement.
No, sir.
Rest of the CNS was not involved.
70% of our patients had tuberculomas in rest of the areas. Only 30% of our patients had chiasmal arachnoiditis.
But these were isolated cases with only chiasmal arachnoiditis, so they had no, rest of the involvement was not there.
Yes, no.
That is also quite high number, I think. And you were also showing the optic nerves were quite swollen and affected, one image you showed. So is it because of the optic nerve involvement or because of the chiasmal arachnoiditis?
Because of the chiasmal arachnoiditis, in this case she had this
optic nerves
patient
are
didn't
quite
have
swollen.
Usually they are not swollen. When the chiasmitis is there, that means some part of meningitis should have been there because the skull base is involved, definitely.
yes, sir.
Very swollen optic nerve which you showed us, I think, in one image.
And no other finding apart from your this whatever the fundus picture you are showing with the MRI finding, the ocular finding, diplopia, because it depends where the tuberculoma is,
No,
whether it is in brainstem or other part of, if it is there in other part of the brain, that means cerebrum, the cerebral hemisphere, then there would not be any ophthalmology findings probably if they are deep-seated
only on doing her visual fields we saw this depressed fields. Other than that, she had no other symptoms other than defective color.
So every patient was having because you are saying lots of rings, so every patient was having that your tubular field just like you have shown, or no?
No, sir. Some of the patients who just had tuberculomas didn't have they had almost normal field defects. I mean, no field defects. But
And 30% you said they were having, there was chiasma involvement, yeah, arachnoiditis.
Patients had chiasmal arachnoiditis.
So all of them, they were having rings. That means the ring lesion was there in 30% of patients.
Yes.
That is very high.
Very high.
In all tuberculomas, because lot of tuberculomas like in the midbrain, in the pulse, we also interested in those tuberculomas because there are a lot of ophthalmic manifestations. And then probably this would have been more interesting to my mind because in isolation, I'm sure there would have been other areas also affected in a good number
One of our patients had that. In the pontine area, there was a tuberculoma, so patient presented with 6 nerve palsy.
Yeah, that is what I was asking.
That is what we were saying, that it is very difficult to imagine that these were isolated in so many, and your series was of about 30-40 cases.
Yes, sir.
So anyway, interesting presentation, but I think you should have taken all the tuberculomas, especially those affecting ophthalmology like pons, midbrain.
Yeah.
And these are the areas which commonly you find tuberculomas, and they have very interesting presentations to us. Even you can have a skew deviation because of these tuberculomas and hydrocephalus. It's a very varied presentation with tuberculosis. I mean, CNS tuberculosis is a very vast subject, so it has very interesting and challenging presentations. Thank you so much for nice presentation. Next problem, over here.
Now Dr. Mohini Agarwal, is she here?
Good morning, everyone. Myself, Dr. Mohini Agarwal. I am working as senior resident in AFMC Pune. My topic for today is tuberculosis and neuromyelitis optica spectrum disorder, a conundrum. As we all know, tuberculosis is a major health problem, and the theme of World on TB Day 2022, it was invest to end TB and save lives. And the story is no different for ophthalmologists. We need to invest to end TB and save vision. So here I'll be reporting 2 pediatric cases with neuromyelitis optica spectrum disorder that did not fulfill the diagnostic criteria for NMO. They were negative for aquaporin 4 antibodies, and the associated undiagnosed tuberculosis at the time of the presentation of those 2 cases clouded the diagnosis and delayed the treatment. So the first case, he was 15 years of male. He presented with rapidly progressive, profound vision loss in the left eye, followed by right eye 6 months ago. The vision was perception of light with accurate projection of rays in both the eyes. And on fundus examination, we could see bilateral disc edema with arteriolar attenuation and venous dilatation with normal FR. On digging more into history, we could found that he had an episode of fever and cough, followed by transient weakness in both lower limbs and urinary retention 10 days prior to involvement of the left eye. The MRI spine was done at that time, and it was suggestive of LETM, which is longitudinally extensive transverse myelitis. So this LETM is one of the specific feature for NMO, and it is rarely seen. It's a rarest presentation in the tuberculosis. So here we diagnose the patient as NMO, but because aquaporin 4 antibodies were negative, so we diagnosed him as under spectrum disorder. But to our surprise, the Cox lesion with cavitations was seen on the chest X-ray, which was suggestive of tuberculosis, and thus the patient was suspicious of tubercular optic neuritis as well. So other investigations rest were normal. The acute phase reactants like ESR and CSF had pleocytosis also. So we treated the patient as tubercular optic neuritis and started the patient on anti-tubercular treatment. But the vision loss continued. It did not improve. So while going through literature, we could find out that there is some association between NMOSD and this thing. So we did not Initially we withheld with these steroids, but in view of continued vision loss and profound severe vision loss at the presentation, we started the patient on these steroids, and the patient improved in the right eye, but by the time he had already developed optic atrophy in the left eye. The similar case came after a few months. It was 8 years old male presented with same diminution of vision, profound vision loss to perception of light, and presented with the same fundus picture, bilateral disc edema. He had also an episode of fever and cough followed by the transient weakness in both lower limbs and urinary retention 4 months prior to ocular involvement. So old MRI was suggestive of LETM, so same. Here we diagnosed the patient as NMO. We could find out that the aquaporin 4 antibodies were negative, and it was labeled as NMO-SD case. MRI orbit were also showing involvement of the optic nerves. But here comes the MRI brain, which was suggestive of cerebral tuberculomas, and it literally clouded our diagnosis. The MON2 test was also positive. Here the chest X-ray was negative, and the ESR were raised, and the blood test, they were suggestive of this in the tubercular atypical optic neuritis was labeled. But as we were already aware of this similar case, so this patient was, this time it was treated as a NMOSD with tubercular association without any delay. And so ATT along with the steroids were given, and to our this thing that we could see the drastic improvement over 3 days, that it improved to 2/60, and over 6 months the vision improved to 6/12 in the right eye and 6/9 in the left eye. So it was only temporal pallor was there. We have saved the eye. So as we all are aware that there is criteria for tubercular optic neuropathy. We have consistent ocular signs and MON2 positive and response to 4 drugs of anti-tubercular treatment. And this LETM, it is one of the transverse, there's a difference between transverse myelitis and longitudinal extensive, that in transverse myelitis, it is only involvement of the 2 or less than 2 spinal segments, whereas in transverse, it is 3 or more than 3. Now, the transverse myelitis itself is very rare in tuberculosis, and so LETM makes it more rarer presentation in these cases. So this all clouded our diagnosis. And we have laid out criteria for neuromyelitis optica spectrum disorder, which the patient presented to us, and children are likely to be seronegative for aquaporin 4 antibodies. So the problem here was that if we start the patient on ATT alone, it causes paradoxical worsening of the vision due to the death of the tuberculosis antigen and causing increased inflammation. And if we start the steroids alone, it could have flare up the TB. So the combination has shown similar response as monotherapy also, but the studies have shown that it prevents paradoxical responses, prevents recurrences, and especially in the cases where you have severe profound loss, like the patient reaching vision to perception of light, we should not withhold these methylprednisolone steroids. So the questions arises here is there any association between the...
Can you just finish it up early, because we are just getting late for the another session.
Yes, sir.
The time is not up. Is it up? Or
Yeah, it is up.
Yes. So there is concurrent use of... So the question arises that concurrent use of ATT and steroid should be done, or is there any association between tuberculosis and NMO? Thank you, sir.
What made you think that this is neuromyelitis optica and not a tubercular optic neuritis from the very beginning? You didn't have any demyelinating lesions on the MRI, did you have?
Yes, sir.
Yeah, in the first that MRI,
Yes,
she was showing that longitudinal segments
Yes,
they
sir.
were involved.
Okay.
All
okay.
in both the
Those were
cases,
suggestive of
Yes.
demyelination.
demyelination.
Okay. Thank you. Very nice presentation.
Right.
We have one more presentation.
Yeah,
to
last
go, I think.
presentation.
Last presentation, please come. But then we can't leave the session, it was first session, you can be late by 5 minutes, doesn't matter. What can we do? Please tell me. This is last presentation. Please don't be so aggressive. It's not even 9. This was first session in the morning. It can go by 5 minutes. Nothing can be done. We can't disappoint the person who is prepared for 6 months and then tell them you will not be present.
Yeah.
So just to quickly start the presentation, I have done the study to evaluate the cone mosaic characteristics in glaucomatous and non-glaucomatous optic neuropathy. So as we all know that retinal ganglionic cell loss is a known event in any optic neuropathy. And since these are the inner retinal layer changes, do we have some outer retinal layer changes? This is what the question is. And there has been a lot of debate related to it. Histological studies that have been done, they have shown that photoreceptors do show some changes like swelling, like in cases of glaucoma. Now recently we have the adaptive optic technology, and that has actually shown the cone mosaic characteristics very nicely. So using this technology, there are few handful studies that have evaluated the integrity of photoreceptors, especially in glaucoma. Again, there are contradictory reports. So with this question in mind, that whether we have these outer retinal changes along with the inner expected retinal changes in optic neuropathies. So this was a cross-sectional study done at RP Center, AIMS. Ethical clearance was obtained with the primary objective was to evaluate these cone mosaic characteristics in optic neuropathies and compare them with the age-matched controls. So what we assessed were the vision, the color, contrast, OCT, and cone mosaic characteristics. We, of course, did the anterior and posterior segment evaluation. So this was the inclusion criteria. Now the age group was 20 to 40. So initially we thought we'll take 40, but then we had to extend the age to 20 to 50 years of age group, because then we could, get a better range of cases. And vision, a good vision, so that fixation could be maintained, and we avoided patients with gross central visual field defects. And this was the technology. The RTX1 retinal camera was used for the imaging, and we analyzed the data that was given was in terms of cell density, spacing, regularity, dispersion, and number of nearest neighbors. So these are the results. We enrolled 20 cases, 10 glaucomatous, 10 non-glaucomatous, and 10 control eyes. And what you can see is that in the first chart, the age, gender, vision, refractive error, and axial length all are matched in the cases as well as controls. Now this matching is important because photoreceptor density is affected not only by age but also by refractive error and axial length of the patient. Then you have a look at the color vision, contrast, RNFL, GCIPL. So all these are significantly affected in cases as compared to the controls. Now coming to the results of the adaptive optics imaging. Now this is a very complicated chart because AO gives you a large number of data points, and since we evaluated the cone photoreceptors at 2 degrees, 4 degrees, and 6 degrees fixation in all the 4 quadrants. So we have a lot of data, but just to summarize and simplify things, you see that be it a glaucomatous or non-glaucomatous, all the optic neuropathies, they showed a decrease in density, spacing, regularity, dispersion, and NN6 values at all the various points in nasal, temporal, superior, as well as inferior quadrant. So we do see that inner retinal, along with the inner retinal changes, the outer retinal changes were quite evident in optic neuropathies. And also what we noted that was most effective quadrant was the nasal quadrant, especially the 4 degree and 6 degree. So this is basically the area which is adjacent to your optic nerve head. So probably because of the affection of the papillomacular bundle, which is affected more so in non-glaucomatous optic neuropathy, that's why probably we had the greatest effect in this area. But of course the cases are few. We need to validate these results with greater number of cases, and we need longitudinal studies so that we can see what subsequent changes are happening on follow-up. So the conclusion is that cone photoreceptors do show structural changes in optic neuropathies in the presence of these inner retinal layer changes, and probably this is the reason why you're getting the color vision defects in them.
Thank you for a very nice presentation, and I think more studies will need to be done to bring clarity to these aspects. Thank you so much. Thank you all of you for the participation. It was very nice, young people presenting their interesting work. Thank you.